So we're lucky to have Dr. Daniella Kadian-Dodov today. Dr. Kadian-Dodov is an assistant professor of medicine in the section of vascular medicine and the new program director for the Vascular Medicine Fellowship in the Zena and Michael A. Weiner Cardiovascular Institute at Mount Sinai. She completed medical school at the Oregon Health and Science University in Portland, Oregon, followed by her internal medicine residency and vascular medicine fellowship here at the Icahn School of Medicine at Mount Sinai. She has publications in basic science research regarding the behavior of endothelial cells and currently focuses her clinical research on fibromuscular dysplasia, as well as related arteriopathies, including spontaneous coronary artery dissection and cervical artery dissection. She was a co-author for the first international consensus on the diagnosis and management of FMD, which was co-published in the Vascular Medicine Journal and the Journal of Hypertension this year. She was nominated to represent the Society of Vascular Medicine on the Vascular Low-Frequency Disease Consortium, which is a collaborative effort among investigators from institutions across the U.S. and the world to study the management and outcomes of uncommon vascular conditions. Dr. Kadian-Dodov is additionally the new site PI for the International Spontaneous Coronary Artery Dissection Registry and a co-investigator in the U.S. Registry for FMD, as well as the Define FMD study, which is a collaborative translational study with the Kovacic Laboratory at Mount Sinai, looking to define the genetics and molecular mechanisms of FMD. Please join me in welcoming Dr. Kadian-Dodov.
Good morning. Thank you very much for having me. It's an honor. So this morning I'm going to be talking about fibromuscular dysplasia, looking beyond the string of beads. I have no disclosures. And so to start, if your training was like my training in medical school, FMD got about 5 minutes of one lecture, and you'll probably remember it as the string of beads. And you may think about it in a woman like this. This was a 47-year-old patient of mine who presented with hypertension and had a carotid bruit on exam. And what you're seeing in the images is the distal internal carotid artery with what you can hopefully make out as beating on B mode, and then turbulence as well. And on her renal angio, she had this appearance, which is the string of beads of the distal renal artery, which we now term multifocal FMD, and I'll get into that a little bit more. But I would ask you to perhaps think about this talk through the context of a family that I follow. So this was actually not the first member of the family that I met. It was her sister, who at the age of 45 had an NSTEMI due to spontaneous coronary artery dissection, which you can see in the image there. And on screening her, we identified that she had carotid multifocal FMD. Now, these two have a third sister who underwent evaluation, and she had no string of beads or typical manifestations of FMD, but she did have splenic artery aneurysms alone. And then finally, in going through the family history, the mother of these three women had experienced Takotsubo cardiomyopathy at the age of about 50. So I will get into how all of these may be manifestations or are manifestations of fibromuscular dysplasia as we know it today. I have two objectives for you this morning. The first is to identify patients in whom the diagnosis of FMD should be considered. And second, to recognize FMD is an actionable knowledge item, which is a term used by Dr. Kim Eagle on cardio Twitter, which is an item that you think about that's of clinical importance, basically. So we'll go back to the history and origin of FMD. This was first described in a 5.5-year-old boy with hypertension since the age of 3 who achieved cure with nephrectomy of an ectopic and atrophic right kidney. This was described in 1938, and in this paper by Ledbetter and Birkeland, they noted that further away from the kidney, there was a muscle plug in the vessel wall, which you can see in the image there, that was in direct contact with the intima of the artery, reducing the lumen to a mere crescentic slit. And it seems obvious that by chance we have stumbled upon a peculiar anomaly of development affecting a renal artery. Now from here, the histology or histopathology of FMD was described basically as an overgrowth of one of the artery layers causing the manifestations of FMD. So if you get overgrowth of the media, you would develop the typical string of beads appearance of FMD. The intima or adventitia would result in a single area of stenosis shown here. Now, because we rarely obtain pathologic tissue today, we've switched over to an angiographic diagnosis of FMD. So the histopathologic descriptions are now termed multifocal if you see the string of beads, or focal if there's a single area of stenosis. And there are differences in how these diseases or these manifestations behave, which I'll get into in a little bit. Now, just as a side note, I want to just put to light that there are some mimickers of multifocal FMD that we do see. One is on catheter-based angiography or CTA angiography. You may see spasm, which is a regular oscillation or irregularity in the artery wall known as standing waves. And then also a healing arterial dissection may have an irregular appearance that sometimes is called multifocal FMD. Important to note. So as a background, fibromuscular dysplasia is a non-atherosclerotic, non-inflammatory arterial disease that affects predominantly the mid to distal artery. It predominantly affects women. It's reported in up to 94% of patients, and usually the carotid and renal arteries, although any artery in the body can be affected. And the etiology and prevalence of this are really not known, even though we're coming upon nearly 100 years since it was first described in 1938. Now, some things we do know about it, there are some differences between multifocal and focal FMD. There's a predominance, as I noted, for women affected with this disease, but all patients seem to experience a delay to FMD diagnosis, somewhere between 4 to 9 years, probably because of overlap with other age-related disorders like essential hypertension, and in some cases, poor provider awareness and knowledge about this. Now, the age of diagnosis differs, so we typically see focal FMD in younger patients and multifocal FMD in our middle-aged to older patients. So that's another distinction that is important to know. In terms of genetics, familial cases are reported in up to 7 and 11% in the literature, but when they've looked for other monogenetic and connective tissue diseases, the rates are very low. So what you're seeing here are genes associated with Loeys-Dietz, Ehlers-Danlos, Marfan's disorder, and some of the other arteriopathies that can also result in aneurysm and dissection. And these genes are show a very low prevalence in patients with fibromuscular dysplasia. Now, interestingly, there is a case report of identical twins with FMD, and the woman on the left had 2 small cerebral aneurysms, bilateral internal carotid artery and vertebral artery, multifocal FMD, as well as bilateral renal artery FMD. Now, her sister had different areas of involvement. She had only bilateral internal carotid artery FMD, as well as splenic artery aneurysm and right renal artery FMD. So suggesting that it's more than genetics that's driving this, although genetics certainly seem to have a role with fibromuscular dysplasia. There may be some environmental factors at play. So what could those be? There's some thought that perhaps mechanical stress points may be involved. We know that FMD happens most commonly in the carotid and the renal arteries, and the renal arteries, as you inspire and expire, rotate up and out. And we see FMD more often in the right renal artery, which is the longer of the two. So perhaps that rotation motion is involved with the change that happens in this position. And if you think about the carotid artery, again, we're seeing it mostly in the mid to distal artery of the carotid and then vertebral arteries, where you may get the most torsion with movement, with head movement. And also important in this picture is showing you the difference of where FMD occurs as compared to atherosclerosis. So atherosclerosis is something that affects the proximal or origin of vessels, particularly at branching points. Other environmental factors that may be at play, we know that FMD patients who smoke have more severe disease and higher rates of aneurysm, although the mechanism of this is not known. And although it is predominantly a disease of women, in studies that have looked at differences in oral contraceptives or parity, there really has nothing has really come to light in terms of differences in female patients with FMD versus matched controls to support exogenous estrogen as a driver for this. So a real shift occurred in about 2008 and 2009 in terms of awareness about fibromuscular dysplasia, and this was the front page of the Wall Street Journal in 2009 showing Dr. Jeffrey Olin with two of his patients. The patient on the left started the patient organization, Fibromuscular Disease Society of America, who really started to support initiatives to further investigate FMD. And from this, I want to transition to thinking about the fact that FMD may be much more common than we have appreciated through the years. And we'll use 4 pieces of evidence to support that. First is data from healthy kidney donors. Second, data from the CORAL trial, which is a randomized trial for atherosclerotic renal artery disease. And 3, incidental findings that are found on imaging performed for other reasons. And 4, when it's discovered in patients presenting for other reasons. So starting first with the data from healthy kidney donors, incidental FMD in potential living renal donors has been reported in about 3.8% of nearly 2,000 patients that underwent renal arteriograms. 75% of those patients were women. And another study looking at CT angio identified FMD in 3.9% of patients. So if that's correct, based on the most recent census data, more than 6 million women in the US have FMD. And to put that into context, the most recent estimates state that there are roughly 3 million breast cancer survivors in the US, including women who are being treated and those who have completed treatment. So FMD would be twice as common as that. Now, switching over to the CORAL trial, this was a randomized control trial looking at stenting versus medical therapy for atherosclerotic renal artery disease. And FMD was actually an exclusion criterion for this trial. Now, when they went back to review imaging by the core lab for over 1,000 patients, about half of which were men and women, they found that 5.7% of patients had incidental FMD that was missed. And if you looked at just the women, 9% had FMD. So in our patients with hypertension, it's even more common and likely has been underdiagnosed. Now, this is a case of a 78-year-old woman who underwent imaging for a completely different reason and was found to have multifocal FMD involving the mid to distal renal artery. And at Sinai, we pick out about 1 to 2 cases like this per month. Now, finally, we've identified over 20 patients that were referred to us in our vascular medicine clinic for completely different reasons, including leg swelling, varicose veins, cardiovascular prevention, exertional leg pain, and then healthy controls in our research trial for defined FMD, which I'm going to talk about. We picked these patients up by listening to the neck and detecting carotid bruits. And what I want to show you is, most people would listen to the neck down here, but where you're going to hear the bruit for FMD, because it's the mid to distal artery, is up by the angle of the jaw. So you'll miss it if you don't go up high enough. I would encourage you to trace that carotid artery all the way up. And this is a 74-year-old woman of mine, patient of mine, who was referred for leg swelling and had cervical bruits on her exam. And what you're looking at are her carotid duplex exams. This is this is the mid to distal carotid artery showing a loop, and then the beads of FMD on the other side. No symptoms at all. And arterial tortuosity is something else that we can see commonly in FMD. This was studied by Dr. Olin through our imaging here at Mount Sinai. So this was a retrospective case control study looking at carotid duplex ultrasounds of over 100 patients between 2009 and 2011, and looking for this S-curve, as we call it, on carotid duplex exam. And this S-curve was identified independently by 2 investigators for all patients. Now, the control was 4 per each S-curve patient in FMD. So 2 were age and sex matched control patients, and 2 were age over 70 years and sex matched for each S-curve patient. And what they found was that if you were below the age of 70 and had an S-curve, you were your odds ratio of having FMD was 16. So much, much more common. And determined that the S-curve occurs much more frequently in patients with FMD compared to patients of similar age or to elderly patients overall, but its presence should alert the physician to the possibility of FMD. So particularly if you're seeing this arterial tortuosity in your patients below the age of 70, you should think about FMD. Over the age of 70 with longstanding hypertension, the arteries can elongate and you can have some arterial tortuosity that's not pathogenic. Okay, so I would like to transition to talking about the United States Registry for FMD, which began around the time of that Wall Street Journal article that I mentioned. This was formed in 2008. It's funded by the FMD Society of America exclusively. It now includes over 2,600 patients across the US and 15 enrollment sites, which are shown there. And we've learned quite a bit about how this disease behaves since the inception of this registry in 2008. The Data Coordinating Center for this is located in Michigan through MCOR. And what we've seen is that this is, as we thought, most commonly a disease of women with multifocal disease, so the string of beads. And the mean age at first symptom of FMD is about 47. Mean age of diagnosis is around 52, so the mean delay is about 4 years. In terms of vascular beds that are involved, this is not something that affects predominantly the renal arteries. It affects the renal and carotid arteries with about equal frequency. Thereafter, the vertebral, mesenteric arteries, and lower extremity arteries are most common, followed by the intracranial arteries. And the clinical manifestations that patients present with are going to depend on which arteries are involved. So if it's the carotid and the vertebral arteries, headaches are very common in about 50% of patients. Pulsatile tinnitus, or patients describing a whooshing sound in their ear, is reported in about a third of patients. You may detect a bruit in up to a fifth of patients. And then symptoms of TIA or stroke are typically related to cervical artery dissection. Patients may have neck pain that radiates up to the face, amaurosis fugax, or Horner syndrome. For renal artery involvement, most commonly we see hypertension in these patients. And aneurysm and dissection are common. So this is data from 921 patients enrolled in the US registry. And what we found was that 41.7% of patients had an aneurysm or dissection detected somewhere at the time of diagnosis. But now, it's important to know that in order to attribute an aneurysm or dissection to FMD, you have to see typical multifocal or focal FMD in another arterial bed, because there are other conditions that can cause aneurysm and dissection. And when you break down where these events occur, any aneurysm was seen in 21.7% of patients, most commonly in the renal and the carotid arteries. What you're seeing here is a renal artery aneurysm on angio, and then during surgery, the same renal artery aneurysm, and a cerebral aneurysm shown here. Now, intracranial artery aneurysm was the third most common, accounting for 22% of all aneurysms seen. And a secondary study was done to look specifically at the rate of intracranial aneurysm in the US FMD registry. And what they found was that out of about 650 patients who had imaging, cerebral aneurysm was detected in 12.9%. And importantly, a high rate of these aneurysms were in a high-risk location in the posterior circulation, about 18%. And if you think about this rate in comparison to what's reported for the population, it's estimated that the prevalence of unruptured aneurysms in a population without comorbidity and a mean age of 50 is about 3.2%, so much, much higher. And the size of aneurysms that was detected was large in many cases. So nearly 30% of those patients had an aneurysm greater than 5 millimeters, and 12% it was unknown, but the aneurysm was repaired, so presumably requiring an intervention. So because of this, you should look beyond the string of beads in all patients with FMD. So these patients should undergo head-to-pelvis imaging, preferably with a CTA, because in the chest, abdomen, and pelvis area, when you use MRA, you can get motion artifact that can sometimes mimic FMD, or you may not have the resolution to pick up an aneurysm in that location. Now, looking at dissection breakdown in this population, Dissection was seen in about 26% of patients nearly, most commonly in the cervical arteries, followed by the renal arteries, and then the coronary arteries, which I'm going to talk about a little bit more. And what you're seeing here is a vertebral artery dissection on coronal view, and also on duplex ultrasound imaging with the double lumen. Now, if you look at the demographics of patients with aneurysm and dissection, overall, patients with dissection present at a younger age, and this may be because they have an acute event and they actually undergo an evaluation. A higher rate of men was seen that have aneurysm and dissection as compared to the overall FMD population, and I'm going to get into that a little bit more, and higher rates of smoking are seen in patients with aneurysm. End organ ischemia or pain syndromes are also more commonly seen in patients with dissection, not surprisingly. So although men with FMD account for less than 10% of cases overall, they seem to have a more virulent course when FMD is present. So we see higher rates of dissection and aneurysm in men with FMD as compared to women with FMD, particularly renal artery dissection. So I would encourage you to not put it aside in male patients. Keep it in mind, especially for those presenting with aneurysm and dissection. Okay, so shifting over to SCAD and FMD, there's been a lot of exciting publications about this over the past few years. So SCAD accounts for up to 35% of MIs in women under the age or equal to the age of 50 years old. It's the most common cause of pregnancy-associated MI, but pregnancy-associated SCAD actually accounts for a small percent of SCAD overall. And more than 50% can recall a precipitating factor before their SCAD event, which may be intense exercise, intense Valsalva, and emotional stress, or recreational drugs and exogenous hormones. And that's not unlike the Takotsubo population, if you think about it. So this is also a cardiomyopathy that predominantly affects women. There's often an emotional stress trigger or some kind of trigger preceding it. And there are cases of SCAD with Takotsubo presentation. And what you're seeing here is a dissection of the mid to distal LAD, and with the ventriculogram, that apical ballooning typical of Takotsubo. So if you see a patient who has Takotsubo cardiomyopathy, I would encourage you to go back, take a closer look at the coronary angiogram, maybe with your cardiology colleagues, and make sure you didn't miss a wraparound LAD dissection, because this is becoming more and more commonly recognized. And taking it back to the patient case that I presented at the beginning, the mother of those 3 women had Takotsubo cardiomyopathy in her 50s. Unfortunately, we weren't able to obtain the coronary angio, but it was very suspicious for her having a SCAD event as well, given what we knew about the daughters. Now, there is evidence that SCAD in general is a manifestation of an arteriopathy, or is an arteriopathy itself. When you look outside of the coronary arteries, multifocal FMD is the most common finding. We see it in anywhere from 17 to 86% of patients, depending on the number of imaged vascular beds and the population and type of imaging that you use. And intracranial aneurysm is seen in 14% of patients with SCAD, according to one patient series. Arterial tortuosity is also common in both the coronary and extracoronary arteries, supporting that there's an underlying arteriopathy at play here. So what you see here is a dissection, again, in the coronary artery with double lumen and coronary tortuosity, which is more commonly seen in patients that experience SCAD. Now, vessel redundancy has also been reported in patients with cervical artery dissection, making the case for commonality between these conditions. So this is a retrospective study comparing 13 patients with cervical artery dissection to over 100 age and sex matched controls, all of which who had cervical neck imaging. And what they found was vessel redundancy, these loops, S-curves, coils, kinks, were much more common in patients with cervical artery dissection, 65% compared to 18.5% of controls. And FMD has been reported with cervical artery dissection patients too. So in the cervical artery dissection literature, they identify FMD in about 20% of patients historically, but it's important to note that those studies did not look below the neck. So it's very likely that they were missing FMD in a lot of those patients. Additionally, patients who have multiple cervical artery dissection, which is about 15% of patients from a large European consortium, were 4 times more likely to have FMD. Looking at it from the other angle, from the US registry data, if you look at patients with FMD, about 19% experienced a cervical artery dissection, which was the most common location of dissection again, and 37% were multiple cervical artery dissections. Now, recently this year, there was a study that systematically imaged patients to look for FMD and try to identify the true co-prevalence of cervical artery dissection and FMD. So this included 230 patients who were referred to the Arcadia-Pol registry, which is related to a French registry. And they included patients with suspected or diagnosed FMD, as well as cervical artery dissections patients and SCAD patients. And all of these people underwent total body CTA, as well as a clinical evaluation to screen for these arteriopathies. And what they found was that cervical artery dissection and FMD occurred in 39.5% of FMD patients. So 39.5% of FMD patients had cervical artery dissection. Other way around. 39.5% of cervical artery dissection patients also had FMD. So there is significant overlap between these two conditions. Additionally, there's data in this that FMD is systemic and multi-site involvement is common. So when they define multi-site FMD as just the beating, they saw it in about 2.6% of patients had multiple sites involved. But when they expanded that definition to include aneurysm and dissection, 44% of patients had multi-site involvement. And this correlates with data from the French prospective Arcadia registry that this is affiliated with, which included over 400 patients. And what they found was when you expanded the definition to include aneurysm and dissection, 66% of patients had multi-site involvement. Again, supporting that this is a systemic arteriopathy with a broad spectrum of presentation. So when should you look for the string of beads? I would say in all patients with SCAD or cervical artery dissection, these patients should undergo head to pelvis imaging, preferably with CTA again, to look for FMD and occult aneurysms. Now, there is some emerging data in genetics to support the clinical commonality that we've been seeing between these conditions. So the factor I gene is a member of the phosphatase and actin regulator family of proteins. It plays a role in actin and contractile filament organization. And the top variant has been associated with an increased risk of cervical artery dissection, as well as FMD and migraines, and a lower risk of MI and coronary artery disease. So again, these are not atherosclerotic conditions. So there seems to be a dual mechanism at play here for factor I. Now, this was also recently replicated in SCAD over the last year. So the same factor I allele was also found to be associated with an increased risk of SCAD, supporting or providing the first genetic basis for clinical overlap between these conditions. And this was from 4 different case control studies pooled together where this was replicated. So there is overlap between these 3 for sure. And this leads me to the Define FMD trial, which is an initiative that we're doing here at Sinai. So this is investigator-initiated study. It's single site, and it's run through the vascular medicine clinic of predominantly Dr. Olin as well as myself. Our target enrollment is just over 600 patients, or at least 600 patients, and we're funded through philanthropy currently. The first run-in subject was obtained in October of 2012, and the first FMD subject in 2013. And the goal of this is to study the functional, molecular, and genetic profile of fibroblasts from FMD as compared to carefully matched controls. And we recently expanded this to undertake a fully powered cross-systems genetic analysis of FMD, as well as the related arteriopathies of SCAD and cervical artery dissection. And Dr. Jason Kovacic is the principal investigator for this study. So in terms of recruitment, we're targeting confirmed FMD patients, 200, and then SCAD and cervical artery dissection patients, 100 patients each, and then 200 controls, which we identify by evaluating for a history, any signs on history of physical exam for FMD, including a blood pressure analysis and auscultation of the neck for any bruits. And these are matched by sex, race, ethnicity, age, smoking, BMI, and blood pressure medications to the FMD patients. And again, we have identified, I think, 3 patients now through our control screening who actually ended up having FMD detected by cervical bruits on exam. So these patients undergo a skin biopsy, punch biopsy. This specimen is taken over to the lab and plated, and then fibroblasts are grown out. And what you see here is a piece of skin in the corner and the dermal fibroblasts growing out from there. And from this, the fibroblasts are harvested to extract RNA and perform RNA sequencing and obtain many, many genes. And our goal is to identify the disease-driving molecular processes that underlie FMD. And so the way that this is done is from the RNA, we're able to obtain gene expression, the fibroblast phenotype through proliferation and migration, and then from the serum, protein and RNA levels, and then DNA sequencing. And this gives us a system genetics evaluation for these patients. We have one person handling all of the cells. This is Valentina and all of her babies. And at this point, we've enrolled 381 patients. Just over 200 those are FMD SCAD and cervical artery dissection, and 174 control patients. And we're recruiting about 1 to 2 patients per week, doing pretty well with this so far. So we did do a data analysis in 2015 for the first 100 subjects that were enrolled with this. This only included FMD patients. It had not been expanded to include the SCAD and cervical artery dissection patients yet. But this was about 57 FMD and then 47 controls who underwent fibroblast RNA profiling under resting and then stimulated conditions and DNA sequencing. And then the data was transferred to a bioinformatics team in late April for evaluation. And from this, they were able to identify 273 differentially expressed genes in cases versus controls. So what you're seeing is genes in controls versus FMD and the level of statistical significance between these. And from here, they did a weighted gene co-expression network analysis. So I'm going to put the caveat in here that Dr. Olin and I are on the clinical side of this study, and the genetics and bioinformatics portion is through the Kovacic laboratory and our colleagues in the genetics and bioinformatics division. So I'm going to do my best to go through this, and I will probably punt any questions on this to Dr. Kovacic, who I see in the audience here. But basically, from thousands of genes, they're able to construct a gene co-expression network and identify clusters of highly interconnected genes, which are called modules. And then they're able to find biologically interesting modules by relating this to external information and measure how co-expressed a given gene is with respect to the genes of the particular module. And then with that, the genes that have the high interconnectivity are key drivers for this network. And so this is what the FMD analysis may look like. This is not the one for FMD, but we've identified basically 4 genes of interest that are likely key drivers for FMD. And this is not going to be one gene driving fibromuscular dysplasia. I think the fact that there's a broad spectrum of presentation supports that as well. It'll likely be many, but ultimately our hope is we may be able to identify a blood test that we could test people for FMD someday, or family members of FMD, when we know the genes that we're dealing with. So again, this is a collaborative effort between the clinical side, Annette King, nurse practitioner, Dr. Jeffrey Olin, myself, and Valentina, who you saw with the cells, and Dr. Jason Kovacic through the Kovacic laboratory, and our other collaborators in genetics and bioinformatics, as well as some collaborators through the NHLBI and NIH. So with that, I'll transition to the management and follow-up of fibromuscular dysplasia. And I'll say, I presented that aneurysm and dissection are common in FMD, and we have no data to suggest that the management for patients with FMD that have these vascular manifestations is any different. So there are no FMD-specific guidelines. General guidelines apply. For acute arterial dissection, I generally will use anticoagulation over antiplatelet therapy for somewhere in the 3 to 6 month period, paired with imaging surveillance. And then for the long term, put patients on aspirin. For patients who have an incidentally identified dissection, aspirin alone is what's used. And for any patient identified with fibromuscular dysplasia, even if they don't have a dissection, in general, we put these patients on aspirin if there's no bleeding contraindication. Thankfully, revascularization is rarely required and is reserved really for just complicated cases of dissection, including continued ischemia despite conservative therapy or pseudoaneurysm formation. So in general, conservative therapy is best, and not mucking around in arteries that are not normal is the way to go. Now, in terms of lifestyle modification, this is probably the area of greatest concern from the patient perspective in terms of what can I do? I have this arterial disease, what am I allowed to do? This is Paul Anderson, who was the original world's strongest man, lifting many people. And in general, you don't want to do this. So you want to avoid intense isometric exercise in Valsalva. There's data from healthy controls that if you're lifting as much as you can with multiple reps, you can generate mean pressures as high as 300 millimeters of mercury, and you can get your heart rate close to 170 beats per minute. So in general, I advise that. I tell them no chiropractic neck manipulation. We've heard of dissections, or we know of dissections that have occurred in that setting. For cardio, I encourage them to do a warm-up and cool-down period always, and don't jump right in. And then I will usually cap out their exercise at 90% of their maximum predicted heart rate, which is 220 minus your age, as a refresher. Because for anybody, there really is no benefit to exercise over this threshold. So particularly for FMD, I will tell them to stop there. For the patient who's had dissection, we've got up there slowly, like you do with cardiac rehab. And then high G-force activities like roller coasters, jerking, motions are the other thing that I will tell my patients to avoid. In general, as I was saying, aspirin daily is recommended for patients with FMD if they don't have a contraindication to taking it. And in terms of follow-up and imaging surveillance in general, we'll get duplex imaging of the carotid and renal arteries every 6 months for 2 years, and then space them out annually if they've been stable. For a patient who's had an aneurysm or dissection, that may change things in terms of what type of imaging and how often we see them. Now, hypertension in FMD is a question that comes up. Which patient needs intervention? Which can I manage with medications? So we would consider renal artery angioplasty in patients with new onset hypertension or resistant or labile hypertension. In that case, you're only going to be doing angioplasty. Stenting is only used for complicated or refractory cases because, again, we're dealing with the mid to distal artery, an area that has a lot of motion and stent fractures can occur. So in general, we try to avoid that. And in thinking about angioplasty for hypertension and FMD, another point I'd like to make is that you can't tell the hemodynamic significance of FMD by looking at it because of those alternating areas of stenosis and dilatation. So what you're seeing here are 4 different renal arteries that look different, but I don't know that I would have suspected that the gradient across this 30 was going to be less than, for example, this artery, or that this artery was going to have a gradient of 50. So we use translesional pressure gradient across the affected area to guide our management, both when we're going to intervene and when we've intervened enough. In terms of intervening for hypertension, we have good data that the probability of hypertension cure goes down with age. Again, people are allowed to develop essential hypertension as well. So just because they have fibromuscular dysplasia doesn't necessarily mean that's the only cause of their hypertension. And also duration of hypertension is associated with lower rates of hypertension cure. So taking it back to the family I presented at the beginning with Pretty typical FMD. And the sister on the left-hand side, the patient with spontaneous coronary artery dissection and carotid FMD in the middle, and then the woman with just splenic artery aneurysms to the right, and the mother with Takotsubo cardiomyopathy. I think we've learned a lot over the past years through the FMD registry, US FMD registry, that what we once thought to be FMD is much, much more than that. So in summary, I'd like to say that FMD is a systemic arteriopathy that presents with multifocal and focal stenotic lesions, tortuosity, aneurysm, and/or dissection. And if there is multifocal or focal FMD in one arterial bed and an aneurysm, dissection, or tortuosity in another, that's multi-site involvement. All patients with FMD should undergo head-to-pelvis CTA to evaluate for occult aneurysm dissection and sites of FMD involvement. And patients with SCAD and cervical artery dissection should also be undergoing this surveillance to look for occult aneurysm dissection and FMD. Finally, I want you to consider FMD in your patients with a cervical or abdominal bruit, and remember the high cervical bruit when you're listening. Early onset hypertension, which I really think about before the age of 40 years. Difficult to control or labile hypertension, your patient with severe migraine headaches, or one who's reporting pulsatile tinnitus or hearing their heartbeat in their ear. And any patient with spontaneous dissection, arterial tortuosity, or aneurysms. And if you are suspicious, you can start here at Sinai with ultrasound. Carotid and renal artery duplex is usually how we'll start screening, and then go on from there if we need to. So with that, I thank you very much. I'm happy to take any questions.
Questions for Dr. Kadian-Dodov?
In the back.
So the twins that you showed us early on had involvement of different areas. So that made me wonder whether maybe there's a second hit. And I think the fibroblast studies you're doing are good and important, but I'm thinking if you could get a blood vessel that's involved, and in the same patient get a blood vessel that's not involved, and look at the genes in each of those areas, you may be able to see what is the second hit. And the other thing is, smoking certainly produces mutagens, and that could be a reason.
Yeah, so I agree with you. I think it's definitely a combination of genetic and environmental hits, and more than one for sure on both sides, genetics and environmental. I think the problem with obtaining affected arteries versus unaffected arteries is that based on what we know about this, it's definitely a systemic disease. So even if you don't see multifocal FMD in an artery, there may be tortuosity there. So the arteries themselves are not normal throughout the body.
I have a question.
Yeah.
So the genomic studies suggested that you had a small fraction that were TGF-beta related, is that right?
Mm-hmm.
So are any of the gene expression profiles related to that TGF-beta? And have you looked at the genetics of that locus in the patients that you've looked in the fibroblasts?
In our study? So I actually don't know. Jason?
Yeah, I mean, thanks, Daniella. The disease definitely weaves in and out of TGF-beta pathways, and we do see some commonality, but there was a study done that Daniella showed where they looked for these classic genes associated with TGF, and they found none of the classic mutations associated with that. In fact, one of our collaborators in Michigan did whole exome through that targeted sequencing through all the TGF-beta loci and was studying it and found nothing specific related to FMD. So it's a great hypothesis and a lot of effort, but it seems that's I think some of, for example, some of the networks we see activate TGF-beta pathways or downregulate. So it is involved, but doesn't appear to be through classic genetic hits as with other diseases.
Yes.
Also, asking about the fibroblast study, you mentioned that you used resting versus stimulated fibroblasts. What does that mean?
So the fibroblasts are starved versus given serum to stimulate them to start activating.
Clinically, so how frequently are you following the patients with full body scans, for instance? Is that?
Yeah, so we do one full body scan, and at that time, we see where the sites of involvement are, and what we've seen in our population, what we know about this is it doesn't appear to be progressive in the sense that you get new arteries forming, beating over time. It appears that a change happens in the arteries at some point in a person's lifetime, and that's it. The only new event that we've seen over the longer term is new dissection, which could happen at any time. So we'll, in general, get the full body scan one time, and then what I'm starting to do is somewhere in the 5 to 10 year range, at least rescan the head with MRA to make sure there's not a new cerebral aneurysm, just because we don't truly know how this evolves over time. Otherwise, the follow-up is usually ultrasound. Dr. Olin.
I would just like to make one comment that this disease is much more common than anybody recognizes. And for the women in this room, at least 4% of you have this. We have screened our controls very carefully with a physical exam and a questionnaire. We've now identified 3 cases of FMD in people who came to us to be controls. So this is seriously underdiagnosed.
Yeah.
In a patient with a moderate to high pretest probability of FMD, is screening ultrasound enough if it's negative, or do you need a CTA to say?
So that's a good question. I would say at Sinai, I would start with ultrasound. Our lab is very familiar with this and will look for it if you put down FMD as the ordering indication. And then from there, if you see anything unusual, and unusual meaning tortuosity alone, and your pretest probability is high, it may be worth getting the CTA in that patient. You can always call us too. We're happy to help.
Okay, let's
All
thank
right.
Dr. Kadian-Dodov.
Thank you.